So I want to touch upon some reform principles, and if any of you saw Speaker Howell's recent editorial, he is highlighting several of these. And this is what we need to do. Not expand plus reform. We need to see that the costs go down and the care goes up before any expansion, period. Number one, the more we can get the federal government out of the way, the better. And in a perfect world, it'd be nice to have a block grant from the federal government. Here's your money for Medicaid per patient. Do with it what you will. Because every state has different requirements. They have a different patient population, and frankly, they have different ideas. And that's where our best ideas are going to come from the state's laboratories, not from the federal government. We should not take any new federal money, and we need to figure out how to get help to those that need it. Because there's a lot of people that are getting help that don't need it. I'll briefly go off track just to give an example of this that I did present at the Merck Commission, where a friend told me about her friend. She had a friend who lived, it's in North Carolina, it's not Virginia, but I'm sure this could happen in Virginia. There's a woman who lives in North Carolina. She's very well off, many acres, has a plane. She renovated a $400,000 home on her property for her daughter and her daughter's husband and their two children. One of those children had special needs, had a disability. So the husband of the daughter, who was living in the renovated $400,000 home, the husband didn't work. He just, didn't feel like working for whatever reason. The daughter got the job of her dreams, and she was making $70 more per month than would qualify her for Medicaid. So they don't have insurance. She could drop her hours or pay to qualify for Medicaid. She's living in a $400,000 home and has a mother whose net worth is several million. Is that right? So we need to figure out how to get the help to the patients that need it, with targeted subsidies, with fraud commissions. So if there are people who are receiving benefits that shouldn't, we need to save the money and give it to those that need it. And welfare-style work requirements would also help. We need to empower patients, and we need to provide compassionate care. We need to expand our options for our Medicaid patients. So what I mean by that is, one example is, each patient could receive X amount of money, and they can either get Medicaid or they can use that money to go out into the insurance marketplace and purchase a plan. Patients need to have skin in the game. They need to have a copay. They need to have a deductible. It doesn't need to be high, but they need to think about the money that is spent. And the only way they will think about the money that is spent is if they're spending some. And we need to expand free clinics, because that can be a wonderful way to encourage charity and to provide care. We need to have cost control, which means capping the total expenditures. We need to use a defined contribution rather than a defined benefit to help control the costs. These are things like HSAs, providing catastrophic coverage, no borrowing by Virginia for this. And I just wanted to touch on what a couple of other states are doing now. There's a lot of ideas out there, but I'm only going to touch on two. In Indiana, they had something called the Healthy Indiana Plan, and patients were required to contribute no more than 5% of their income. They're on Medicaid, and the state would supplement that amount up to $1,100 and put it in an HSA for them. And what Indiana found after 5 years is they were just hoping to be budget neutral, and they saved $1 billion. And there was no change in health. There are ways to do this other than creating an increasing dependent population. In Florida, what they're doing there is they're providing their Medicaid patients with a variety of different plans, not just one Medicaid plan for all, but they have a Medicaid plan if you have, for example, diabetes. They may have more than one plan that you can choose from. And they're bringing in the private insurers. This is helping drive down the cost because there's competition for this market. They're also trying to work on more community-based long-term care, because long-term care is a big component of Medicaid in nursing homes. They're trying to transition more patients out of nursing homes and either into the home or into community centers. That's saving money too, and it's not compromising health care. That's the important thing. So where do we go from here? Here we go. This is where we're going. We're going right into the storm. Jen, Peck, and Paul. We're going right into the storm. Here's the head. And because I didn't really feel appropriate drawing analogies of myself and Jim Cantori. Here we go. Right into the fray. So we know with Medicare, we have cuts of $716 billion. We have IPAP, we'll have rationing. We see that every time we get a new estimate of the healthcare law, it's increased. It's not decreased. We're now seeing some of the new taxes hit. And we're doing all of this to take care of anywhere between 12 and 23 million uninsured. And CMS, back in 2010, said even after the full implementation of Obamacare, there's still going to be 23 million patients that aren't insured. So we're doing all this, and we're not hitting our goal. Let's combine this with a doctor shortage of approximately 100,000. It has nothing to do with Obamacare, and we're really in for it. We're going to see decreased access, decreased choice, decreased quality, increased weight, increased cost, and rationing, unless we can change things. So what can we do on the state level, and what can we do on the federal level? Because I don't think that giving up is an option. There are some bills coming out on the state level, both to be supported, and in a minute I'll highlight one to be opposed. But this is one of the ones, and I've heard there are going to be other ones that come up. So there's HB 39, Medicaid alternative, and doctors donate 4 hours per week to Medicaid eligible population for primary care in exchange for malpractice coverage. And that's not just malpractice coverage to take care of those patients, it's malpractice coverage to take care of all the patients. And there's actually a similar law that's being proposed by this woman here in New Jersey. This is Dr. Alita Eck. She's actually now running for Congress. And she's been doing this in her practice with a significant, like 1 day a week she does just charity care. The advantage of doing something like this is that it does not involve any tax dollars. There's obviously no expansion of Medicaid. This encourages true charity. You know, I go take care of a patient. There's, I'm not trying to get reimbursed for anything. I take care of the patient. And this decreases defensive medicine. Oops, sorry. And so that is one of the options to be considered. And there will be some others that will be coming out in the next couple of weeks. But on a state level, the number one thing that we need to do is not just block Medicaid expansion, which is absolutely imperative, but we need to grab the compassionate argument and move forward with it instead of leaving it to the left. Because Medicaid expansion is not compassionate care for the needy. It's expansion of a huge bureaucracy. And we need to do things like expand free clinics, so on and so forth, that really take care of the patients that need it. Now, there are two bills I just found out about yesterday that we need to oppose. And these establish state exchanges. This would cost Virginia $110 million, and it doesn't give us any additional say. There's no advantage to Virginia establishing a state exchange. We're going to be forced to do anything, let the feds do it. While I was up in D.C. in mid-November, I had the wonderful opportunity to meet this gentleman who is, a physician rock star as far as I'm concerned. And I had the opportunity to see him speak as he received an award. And he's a big champion, Dr. Ben Carson, of HSAs, health savings accounts, because these bring control of healthcare out of the third-party payer where it shouldn't be and back to the patient and to the physician. And he actually has a plan that he puts forth, or they put forth in his talk, And we said, you know what? We should get everybody, not just the Medicaid eligibles, not just the Medicare eligible, but the 370 million Americans every year. Let's give you $2,000 in an HSA. That's $634 billion, which is much less than the Obamacare cost. This money in the HSA, unlike some of the flexible spending accounts that some of us may have, doesn't go away if you don't use it. It can accumulate year after year. If you don't need the money, but a family member does in their health savings account, you can transfer it to your family member. This almost creates a little insurance company within the family unit. You can even donate 5% per year to somebody outside of your family. And the employers, should they choose, can donate to your HSA. You can also bequeath it, because we know that 40 to 50% of healthcare is spent in the last 6 months of life. And I mean, I'll tell you, if I'm sitting there not doing so well, and doctor comes in and says, okay, we can order another CT, we can order an MRI, see if your cancer spread or what have you, and it might add another 3 months to your life if we find something, we give you some chemotherapy. If I have a choice of that under the current plan where, I don't care, it's not my money, right? It's not my money. It is, but it's not. Versus if I have an HSA and I could say, gee, 3 months of life, is it worth the remaining $30,000 I have in my HSA? I'm just going to leave that to my kids. So this encourages compassion, which is really what we need. And the family accumulates wealth, and this plan gradually phases out the government. There are ideas out there. A couple other miscellaneous ideas from Ben Carson, and I'll move on. He's also a big fan of each patient having their own electronic medical record. So he gives an analogy: you could have it on your ring or a necklace or scanned onto a card. So if you're in an automobile accident and you're up in Vermont, then they can just take that card and scan it. They have your EMR. They have your electronic medical record. That's going to give you better care, and it's going to save money. Tort reform is obviously a big missing piece of any control of healthcare costs, but that's another talk in and of itself. I just want to say that PPACA is not about care. It's about control. So I'm briefly going to touch upon on the federal level, because frankly, we need to get the Senate before these are viable options. But just to point out that there are alternatives on the federal level out there. This is Congressman Tom Price, orthopedic surgeon from Georgia. He has Empowering Patient First Act, and Congressman Ridgell is also a co-sponsor on this. And Congressman Price has these ideas to cover the uninsured and underinsured with these tax credits that can be used for health care insurance, up to $5,000 per person. We need to bring the state high-risk pools back that were shut down by PPACA. We can cut costs by allowing insurers to sell across state lines, by allowing individuals and small businesses to pool together for bargaining power, and of course, the missing liability reform. We can increase patient choice by allowing equal employer contribution rule. What that means is that your employer can offer you insurance, or you can take that money they would spend on your insurance and go out in the marketplace and buy your own plan. Does the same thing with beneficiary choices of Medicaid and CHIP, meaning you can either be on Medicaid or you can take that money from Medicaid and go buy a private plan with any additional money that you have. So, question is, how will we be standing after the storm is passed? I'm leaving my options open. Thank you.